Our topic of discussion will be carcinoma larynx, right? So, let's look at the etiology of carcinoma larynx. It is most common in males, especially who have the habit of smoking and alcoholism. Okay, so carcinoma larynx is most commonly seen in smokers and alcoholics, and very important exam question over here. The most common type of carcinoma larynx that we usually come across is the squamous cell carcinoma. Okay, please make a note of this. Most common type of carcinoma larynx is the squamous cell carcinoma. Now the most common site, another very important question, is the glottis. Okay, so in carcinoma larynx, the most common site is the glottis, that is the carcinoma of the glottis, and of course whenever the glottis is involved, we know that it presents with hoarseness. So the most common presentation of carcinoma larynx will be hoarseness. Okay, now let's look at the prognosis. The best prognosis is obviously for early presentation and that which has a late spread. Okay, and another very important and confusing exam question over here is the most common presentation of carcinoma subglottis. See, the most common presentation of carcinoma glottis is hoarseness, whereas subglottis, S for sub and S for stridor. Okay, so remember it like that. Subglottis is for stridor, and this type has a very poor prognosis. Okay, now with that note, let's proceed to how we will diagnose carcinoma larynx. So the investigation of choice, always remember, is direct laryngoscopic biopsy. Obviously, we know that tissue is always the gold standard for any diagnosis. So the investigation of choice for diagnosis will be direct laryngoscopic biopsy. However, there is always a risk of iatrogenic spread of the tumor. So we have an advent of so much of technology, so we can either go for a CT scan or the MRI of the neck. Okay, so what do we understand by the CT scan? We can do the TNM staging of the tumor, especially the tumor T of the TNM staging we stage via the CT scan, and for the M, that is for distant metastasis, we go for a chest X-ray. So now let's look at the TNM staging in detail. We have already seen how N and M are classified in our previous class, so now I will be concentrating only on the T staging of glottic cancer. Okay, so T1, the patient presents with normal vocal fold mobility. Okay, in T1a, one vocal cord is involved, right? And in T1b, both the vocal folds are involved, right? So T1a, only one is involved, whereas T1b, both the vocal folds are involved. When we look at T2, as opposed to T1, which has a normal vocal fold mobility, T2 presents with an impaired vocal fold mobility. Okay, and T3 obviously will be the worst stage, that is with a fixed vocal folds, that is complete paralysis of the vocal folds. Now, there are three P's that we have to remember. So, in T3, the tumor can be in the pre-epiglottic, paraglottic or the post-cricoid area. So, when we look at T4, that is present outside the larynx, right? T4a and T4b, it spreads into the superior mediastinum or the prevertebral space, or it even encases the carotid artery. So this is the T staging of the glottic cancer, right? Now let's proceed to TNM staging of the supraglottic cancer, right? So there are 5 subsites of supraglottic cancer. It can be suprahyoid epiglottis, infrahyoid epiglottis, arytenoids, vestibular folds and aryepiglottic folds as well. Okay, so when we look at the TNM staging, T1, only one subsite is involved. In T2, more than one subsite is involved, including the mucosa of the base of the tongue and also glottic spread. Okay, and in T3, there's vocal fold palsy, and in T4, there is an spread outside the larynx, right? So this is same as that of the glottic cancer. The spread can be into the superior mediastinum, prevertebral space, or even the carotid artery. Okay, now let's look at the TNM staging of subglottis cancer. T1 and T2 are usually not considered because this cancer presents very late, okay? And T3 and T4 is easy for you to remember. It's same as that of the glottic cancer, okay? With that note, let's now proceed to the treatment of carcinoma larynx. So T1 and T2 stages, the treatment of choice, R1OC, that is the first treatment of choice, will be radiotherapy, okay? There will be a follow-up of 6 weeks which will be required from the patient if he undergoes radiotherapy. Okay, however, there is another option for T1a, which we are calling it as laser chordotomy. We just remove that mass from the larynx using a laser. Okay, however, the problem with this is the voice results are poor, but the only advantage is that the treatment is done in a single sitting instead of having a 6-week follow-up like radiotherapy. But the patient will have to compromise on his voice quality. Right, now, what do we do with T3 lesions? There's concurrent chemoradiotherapy. That is the treatment of choice. Okay, so concurrent chemoradiotherapy is the treatment of choice for T3 lesions. And however, there is an exception where we have to go for surgery as the first treatment of choice. That is in case of bulky lesions, in case of associated lymph node involvement, and whenever there is multiple site involvement. Now, very important, perichondritis is an absolute contraindication for radiotherapy, right? So surgery is the treatment for cases with perichondritis. Now let's proceed to the treatment of T4 lesions. Here we use a combined modality of both surgical management followed by radio and chemotherapy, right? However, T4b, that is the final stage, we will obviously give only palliative management, right? So T4 lesions, we go for a surgery followed by radiochemotherapy, and then T4b, we only give a palliative management. Now the surgery of choice that we do is the total laryngectomy. Okay, so what is this? Here, a high tracheostomy is done in total laryngectomy. So usually, tracheostomy is done between second, third tracheal rings. Okay, when I say high tracheostomy, it is done between first and second tracheal rings. Right. So once we do a laryngectomy, we know that the patient has lost his voice quality. So how will we rehabilitate the voice? Now there are a few modalities that we have to understand. The first one we are looking at is the electrolarynx, right? So as you can see in this image, a small handheld device is used for mechanically vibrate. So the patient can produce sound from his voice box. So the disadvantage is that there is only one tone of voice that is produced, that it is monotonous. He cannot vary the tone of his voice. That is the disadvantage of handheld device. Now, as you can see over here, this handheld device is held, vibrated, and hence produce the speech. Because of its disadvantage, the next modality that is chosen is the esophageal speech. Here the airway is separated from the digestive pathway. Okay, so as you can see over here, the air that is swallowed by the mouth enters into the esophagus, and this air itself is used to create the vibration and produce voice, right? The disadvantage is that the patient can speak only a few words at a time because the amount of air that he can inhale for production of speech is limited, right? So that is the disadvantage. Now the best modality is tracheoesophageal speech. Okay, it consists of a one-way valve which is placed between trachea and esophagus, right? So this is also known as tracheoesophageal voice prosthesis. So the person can speak complete sentences, and obviously it is the best way of voice rehabilitation. However, the only disadvantage is that it has to be replaced again and again once in 6 months to 2 years, and also it is expensive. So as you can see here, this is the valve that is placed, that is the tracheoesophageal